Hello, I'm Satyajit Das. I'm going to present the second part of my last video posted last week. So, first of all, thank you very much for putting your comments in the comment box and also sending many comments to me directly. I really appreciate your responses, and most of the responses were accurate or very close to the final diagnosis. So let us go through the case and discuss the diagnosis and management and some learning points. This is about a 59-year-old female, known diabetic, hypertensive and COPD, smokes cigarette for 40 years, presenting with fever, progressive shortness of breath, chest pain and diarrhea. She was hypoxic, tachycardic and tachypneic. She had impaired renal function and impaired liver function test with raised ALT. She has raised inflammatory markers including leukocytosis, raised troponin T, and positive test for anti-nuclear antibody and anti-nuclear cytoplasmic antibody. Her diabetes was poorly controlled as evidenced by raised HbA1c. Her CT chest showing consolidation and ECG showing atrial fibrillation with gross ST changes in all the leads, and transthoracic echocardiogram showing impaired ejection fraction with small pericardial effusion and global thickening of the left ventricle. The wall motion was normal. Her COVID test was negative when she was tested for the first time. So what is the diagnosis? Well, you have done very well. The diagnosis indeed was influenza with secondary bacterial infection and septicemia leading to myopericarditis and renal failure in a female patient with poorly controlled diabetes and COPD. Let us now discuss the other important differentials, which included pulmonary embolism with infarction or hemorrhage was excluded by the chest CT scan. Pulmonary tuberculosis was considered given the right lower lobe consolidation. However, the patient had no risk factors for tuberculosis such as recent travel and no history of weight loss or night sweats. In addition, the acute onset of symptoms and the negative acid-fast bacilli smears goes against the diagnosis of tuberculosis. Aspiration pneumonia with acute myocardial infarction was excluded as she had no risk factors for aspiration such as loss of consciousness or altered mental status. An acute ischemic event was ruled out given that her transthoracic echocardiogram showed no wall motion abnormality and her ECG revealed diffuse ST segment elevation in all the leads and with atrial fibrillation. These findings are consistent with myopericarditis but not with acute myocardial infarction. A positive ANA test with low theta and a positive ANCA test with multi-system involvement alluded to the diagnosis of ANCA vasculitis, but the subsequent ANCA subtypes including PR3 and MPO came back negative. These were suggestive of a possible response to septicemia rather than any vasculitic reaction. The raised leukocytes, CRP and ferritin levels with impaired renal function and raised ALT were all likely to be related to septicemia. Her respiratory viral PCR assay was positive for influenza A H3 subtype. A sputum culture with gram staining was positive for Staph aureus and a blood culture was positive for Staph aureus 2, suggesting that she had septicemia due to Staph aureus. Another COVID test came back negative. Considering COVID-19 in patients with or who present with influenza-like illness is vital because symptoms of influenza often overlap with those of COVID-19. The secondary complications of both diseases are similar. Of note, COVID-19 and influenza can occur together. So it was very important that COVID has been ruled out in this case. So because the patient has uncontrolled diabetes and COPD, she is at risk of complications from influenza. So how did we manage this patient? The patient was intubated, fluid and electrolyte balance was maintained. She completed a 5-day course of antiviral therapy. She was extubated on day 5 of her admission and was discharged a few days later to complete a 2-week course of antibiotic, which was matched with her culture and sensitivity test. She promised to take diabetes seriously and also promised to stop smoking. I hope she does. Identifying patients who are at risk for complications of influenza is imperative, and early diagnosis and initiation of empiric treatment if influenza is suspected is very much important in such patients. I have added a link which you may like to have a look, where I have discussed about this case in detail, and I have also discussed in some more detail about topics related to influenza and how it should be managed. I hope you have enjoyed this case. Very soon I shall present another case which will be a bit different from this particular case, but I am sure you will enjoy that case too. Bye for now, and thank you once again.